Today we will discuss about IUI. IUI is a very important aspect of ART because all the patients cannot afford to go for IVF, and there is definite role of IUI in selected cases. The injudicious use of IUI should be avoided. Many times the results of the IUI are over exaggerated. In the best of the ART center, the success rate of IUI ranges between 10 to 16%, very rarely up to 18%. Most of the center it is ranging around 10 to 12%. So it should not be overrated and it should not be considered as a sort of step ladder, like first control ovarian stimulation with time intercourse. If it doesn't work, then control ovarian stimulation with IUI. If it doesn't work, control ovarian hyperstimulation with IVF. No, which is not absolutely true in all cases. There is a definite role of IUI when there is a mild male factor responsible for subfertility, or there may be a cervical factor, or if there is a unexplained infertility. In the rest of the cases, IUI should not be used unless it is indicated. Now, the success of the IUI, that depends on the patient's selection, whether patient is young or maybe old. It depends on ovarian stimulation. It is stimulated with the oral drug or it is gonadotropin. How you monitor the response, whether you maintain the timing of the SCG administration, how is your semen preparation, whether you maintain the timing of the insemination properly or not, how is your technique of semen preparation, and there are further attempts can be made to improve the result of the IUI. When you are planning to do IUI, you always aim for development of one dominant follicle and one or two maximum codominant follicle. So if the limited multifollicular development up to 2 to 3 follicles are there, then the success rate of the IUI is more. So very commonly you tempt to combine your oral drugs with the gonadotropin, and which is fairly good idea. It cut down the cost with the giving the same effect of exclusive gonadotropin. Now commonly, since the letrozole is banned in India, the oral drug clomiphene citrate is combined with the gonadotropin to give a multifollicular growth. Now there are different ways of combining clomiphene citrate with the gonadotropin. For example, clomiphene citrate given from day 3 to day 7, and if you think that only you want to try only one injection once only, then the ideal time will be day 9. HMG 150 unit to be given on day 9, and then see the response. If you find it inadequate, then you can give in a different way. The another way is either clomiphene citrate or maybe anastrozole aromatase inhibitor. Aromatase inhibitor is especially useful when there is a high BMI patient. The same way, CC or anastrozole given from day 3 to day 7, and if you want to give gonadotropin limited only 2 injections, then ideal time will be day 6 and day 8. The another way of adding gonadotropin will be if you give a clomiphene citrate standard way day 3 to day 7, and HMG 150 is given on day 3 fixed dose, 150 and day 8. The day 3 HMG helps in the recruitment of the extra follicle, and day 8 HMG, it is believed that by giving an extra dose of gonadotropin, which gives a extra follicular growth, which secretes the estrogen and which takes care of anti-estrogenic effect of the clomiphene. So the success of the IUI is better. This regime, especially day 3, fixed dose of day 3 and day 8, it is promoted by Dr. B.N. Chakravarti. The another way, which is commonly practiced, way of giving gonadotropin is clomiphene day 3 to day 7 plus HMG 150 day 8, day 10 and day 12, 3 dose, and then assess the follicular growth after 12th day. So when you are giving CC day 3 to day 7, and to make it economical, still you want to have the advantage of gonadotropin. Once the follicle, lead follicle crosses 10 millimeter, 10 to 12 millimeter, the gonadotropin in the form of SCG 200 units can be given, which will take care of the further follicular growth. Smaller follicle will not sustain, but the follicle which has already crossed 12 millimeter will grow because of the presence of LH receptor once the follicle has crossed 10 to 12 millimeter. If you want to give a gonadotropin with the CC, very recently a study has come up who tried HMG 75 milligram daily from day 3 for 5 days, and they started clomiphene started 50 milligram TDS from the last day of HMG till the day of trigger. The rationale of this way of using HMG initially only, which helps in the recruitment of the extra follicle. Within 5 days, the good thickness of the endometrium is formed, good amount of estrogen is secreted, and good number of follicle they have already started developing after good recruitment. The CC clomiphene 50 milligram 3 times from the last day of HMG, which boost a further FSH secretion to maintain the growth, and the most important, the clomiphene citrate, which occupy the estrogen receptor, so the pituitary will not recognize rising estrogen, so there won't be LH surge till the CC is continued. So in this protocol, in the very economical way, the premature LH surge is taken care. The injudicious use of gonadotropin should be avoided. There are certain important conclusions which I came across while a review of the literature are worth knowing. Nowadays, the only indication for gonadotropin in non-IVF cycle is CC resistant PCOS and hypogonadism disorder. These are the only two valid indication of using gonadotropin in non-IVF cycle. In rest all other indication, if you use a gonadotropin, the results are same as CC or maybe marginally better than CC, with the remarkably increasing the cost of cycle. So injudicious use of gonadotropin should be avoided. Gonadotropin works well especially in elderly patient or difficult type of the patients. The another important conclusion, the recombinant FSH achieves per cycle higher pregnancy than highly purified FSH. So, if you want to compare highly purified FSH with recombinant, yes, recombinant is better. With the recombinant FSH, the multifollicular development is achieved, but the disadvantage is the P level is also high. So there is a higher chances of endometrial advancement which can compromise the success rate. The highly purified HMG gives rise to single dominant follicle without intermediate follicles. The clinical pregnancy rate is same as recombinant FSH, and highly purified HMG results better in advanced age group. Now, how to maintain the dose? Suppose you have started gonadotropin, how long you want to maintain the same dose? The initial dose is maintained for 6 days before changing according to the ovarian response. Normally in IVF, we maintain the same dose till stimulation day 4 or maximum 5, and then we change over the dose if there is increment or decreasing the dose is required. Whereas in IUI cycle, the same dose is maintained for 6 days. Normally, when you are giving gonadotropin, and once the lead follicle reaches 14 millimeter, ideally you should step down the dose to avoid ovarian hyperstimulation, to avoid multiple growth of the follicles, thereby avoid the multifetal pregnancy, and of course cutting down the cost. So in dose finding study, they concluded the most cost effective dose of gonadotropin ranges between 75 international unit to 112 international unit if you really want a single pregnancy. Higher dose have chances of hyperstimulation, multifetal pregnancy, and there are high chances of conversion to IVF. There is a controversy regarding the usefulness of antagonist in IUI cycle. But if you use the antagonist correctly, it is definitely advantageous. Using antagonist allows reaching multifollicular development without fear of premature LH surge. So obviously, clinical pregnancy rate is better. It is beneficial in patients with proven history of premature luteinization or spontaneous ovulation, many times which is seen in PCOS cases. To understand the usefulness of antagonist, the CPR clinical pregnancy rate with the antagonist 3 cycle has been shown 52%, and if you do not use antagonist, the success rate is around 31%. So in 3 cycle, there is increment of 20% success rate. Some studies not showing any significant changes in the result, so they do not recommend routine use. Whenever you are using antagonist in IUI cycle, the strict criteria of starting antagonist in IVF cycle is around 13 to 14 millimeter. Here in IUI cycle, it can be kept 15 to 16 millimeter. So maybe 1 or 2 dose of antagonist will be required, not more than that. In many times it happens, especially in PCOS, there is a prolonged stimulation going on and prolonged follicular phase. So one of the research paper, they suggested that the triggering ovulation after cycle day 18 did not have a negative effect on the outcome of ovulation induction with IUI cycle in patient with PCOS or ovulatory dysfunction. Although the further research is needed to determine a cutoff after which day the continuation of the cycle becomes futile. This is very well proven in IVF cycle. In IVF, it is clearly proven that if stimulation lasts longer than 13 days, the chances of success are very less. The exception is PCOS. But in IUI cycle, still it remains to be defined up to what time we can pull further. For better success rate in IUI cycle, trigger is must. The timing of the trigger should be correct. Commonly, the SCG trigger in the dose of 5000 international unit is used. Agonist trigger is not used and it is not advisable in IUI cycle. The optimum size of follicle is 21 millimeter or day 14, whichever comes earlier, especially when you have used clomiphene citrate or letrozole for the ovarian stimulation. I am repeating. If you have used clomiphene citrate or letrozole, the trigger criteria, the optimum size of the follicle whenever it is reaching 21 millimeter or the cycle day 14, whichever comes earlier, the trigger should be given. But if you're using a gonadotropin for the stimulation, then whenever the lead follicle reaches 17 millimeter or at least 3 follicle more than 15 millimeter, the trigger should be given. There are lot many methods for the sperm preparation have been described, but the sperm having abnormal motility and morphology, the density gradient is better. Although the current evidence does not support any method better than others, the gradient method works better in unexplained infertility. In male infertility, both the method swim up and density gradient yield same results. Coming to the technique of insemination. Normally lithotomy position is given. Clean the vulvovagina with saline. Take care to clean vagina very gently. Insert the speculum. Clean the cervix with normal saline. Remove excess mucus with gauze gently. Manipulate the speculum. We commonly use bivalve Cusco speculum in a such a way that cervix should look upon you. That means the cervix is central, so automatically which is going to correct the angle between cervix and uterus. Use curved long catheter with a side hole near the tip with demarcation and cervical guard. In difficult situation, curved catheter helps in negotiating irregular, long, deformed cervical canal. The insemination should be as atraumatic as possible. Try avoiding holding the cervix either with the Alice forceps or any other instrument. The time to be taken 60 to 80 seconds while insemination. The sperm should be deposited slowly, approximately zero point 0.5 centimeter below the fundus. In about 80% of the cases, the negotiation of the internal os is easy, and about 20% of the cases, the negotiation is difficult. Now, why there is difficulty? The internal os may not be in the straight line with the external os. This could be a one possibility. And second thing, in 80%, internal os is on the left side of the cervix and 10% is on the right side. So 10% this may be located centrally. Whenever you are facing difficulty in negotiating the internal os, make sure that cervix is in central position of the vagina by speculum manipulation. The external os should be in the transverse axis of vagina. If a catheter negotiation is difficult, as a last resort, use Ellis tissue forceps. After injecting a local anesthetic agent on the anterior lip of the cervix, wait for some time and then use Ellis. Or as a last resort, do cervical insemination. Now, time from the collection of the semen to a process should be between 20 to 60 minutes. So, delay more than 60 minutes from the collection is never advisable. The final semen preparation, final inseminate to be kept at 37 degree for 40 to 80 minutes for sperm decondensation to happen to increase the clinical pregnancy rate. It has been observed that in normal semen, the sperm decondensation is less than 75%. And if you keep at room temperature after preparation for 40 to 80 minutes, the sperm decondensation crosses more than 80%, and which is important criteria to increase the fertilization and clinical pregnancy rate. The Pont reported that the catheter flushing with the culture media to remove microparticles improves the success rate by 49%, but another study failed to show the similar results. So it is up to you whether you want to flush with the culture media or not, but there is definitely no disadvantage. The inseminate volume should be kept minimum 0.3 to 0.4 ml. Some suggest 0.15 ml because the endometrial cavity capacity is quite less and you do not want to inject the higher quantity of the inseminate because it will leak outside, it will initiate the uterine contraction, and all the effort of insemination will go waste. The injection of the inseminate should be very slowly and gently. Tell the patient to take deep breathing to create a negative pressure in the peritoneal cavity, which will help in the movement of the sperm upwards. After insemination is over, the supine position is maintained 5 to 10 minutes and then the patient is allowed to stand up. When you are using the frozen semen sample, bring it to the room temperature, then keep at least for 20 minutes at 37 degree before transfer. The frozen IUI ready sample has more total motile sperm compared to a frozen raw sample, but the difference is not significant. So whatever is available with you, you can use. But if choice is given, whenever you want to use the frozen sample, you should always use IUI ready sample. The another question comes whether luteal support is to be provided in IUI cycle or not. The gonadotropin cycles are clearly benefited by luteal support with the progesterone because the gonadotropin leads to a multifollicular development which leads to higher supraphysiological level of estrogen, negative feedback on LH, and because of the low LH level, the luteal function is also defective. So, the support with the progesterone is must whenever you are using gonadotropin for the IUI stimulation. But the things are different when you are using clomiphene citrate because clomiphene citrate leads to increased FSH secretion along with the LH. So the LH secretion and LH level is also significant when CC cycles are there, and this LH is sufficient to take care of the luteal function. That is why in CC cycle the luteal support is not recommended. Although isolated studies have shown the utility of progesterone and improved result in CC cycle also. The luteal phase progesterone in infertile ovulatory women undergoing treatment with CC and IUI had a significant increase in clinical pregnancy rate as compared to a woman not receiving luteal phase progesterone after adjustment of predictor of pregnancy. This is what I discussed. Now few words about the endometrial thickness in IUI cycle. The Dickey reported no pregnancy when the endometrial strip thickness was less than 6 millimeter. The clinical pregnancy rate increases gradually with the increased endometrial thickness till 10 millimeter. After that, it becomes stationary, and if it is more than 14 millimeter, it is detrimental. In CC induced cycle, the thin endometrial strip should not be used to make a decision to switch over another treatment strategy unless the endometrial thickness is less than 6 millimeter. Anything more than 6 millimeter is okay in CC cycle. The pre-ovulatory endometrial strip thickness and the endometrial echo pattern has no predictive value on the pregnancy with CC cycle. Interesting to know that clinical pregnancy rate is still more than 10% if the endometrial thickness was more than between 4 to 7 millimeter. So endometrial thickness in IUI cycle is overrated. You should not take it too seriously, and you should not postpone or cancel the IUI cycle just because the endometrial thickness is less, provided the pattern is trilaminar, which gives a reasonable assurance about the quality and receptivity of the endometrium. The one study compared a tamoxifen with low dose clomiphene and gonadotropin, especially when the endometrial thickness was less than 6 millimeter. What they observed: the pregnancy and live birth rate were statistically significant in tamoxifen and gonadotropin group compared to CC. The tamoxifen results in monofollicular development. Although in PCOS patient, tamoxifen results in higher cancellation rate due to non-response, whereas cancellation in clomiphene citrate were more due to luteinized unruptured follicle and thin endometrium less than 6 mm. In PCOS, women with tamoxifen had longer follicular phase than CC and gonadotropin. In gonadotropin group, the cancellation were mainly due to multifollicular development, that is more than 4 follicles, and there were no multiple pregnancy in tamoxifen group. So the conclusion was the tamoxifen can improve endometrial thickness and live birth rate in patients with thin endometrium after CC. Though its outcome is comparable with gonadotropin, it is devoid of complication, which is a plus point over gonadotropin. What is the minimum sperm count required for the success? There are a lot of controversial studies and controversial conclusions, but by and large, total motile sperm more than 7 million is most important. Another study which has shown unchanged outcome with total motile sperm more than 1 million and the morphology more than 3% in final inseminate volume. How many number of the cycles are advised, should be advised? Normally, IUI is offered 4 times if the infertility is less than 5 years and 6 times if there is a ovulation disorder. There is no point in more than 3 IUI cycle as the 96% of the pregnancy occurs in first 3 cycle, but to be on safer side, 4 cycles can be offered. The clinical pregnancy rate decreases with the increasing number of IUI cycle. So if the IUI cycle is to be successful, it is successful in first 3 or 4 cycles. Younger the patient, higher the clinical pregnancy rate. Clinical pregnancy rate declines more rapidly in younger patient as the number of the cycle increases. Whenever the CC-HMG stimulation protocol is used for IUI and if it fails, 2 or more resting cycle is advisable to improve the result. Many times the question comes about whether to go for single IUI or double IUI. It has been proved that there is no benefit of double IUI D, means donor sperm, over single IUI D. The most studies proved no advantage of double IUI over single, except those are done for mild compromised semen. So, except a mild male factor, there is no advantage of double IUI. Silverberg found double IUI more useful, but by going into depth of the study, we found that the 25% of the cycles in the study were frozen sample. Now coming to the timing of the single IUI. There are again various studies, lot of controversial conclusions. Overall, 32 hours to 40 hours after SCG trigger or a day after positive LH test, urinary LH test, is the ideal time of single IUI. The single IUI 12 hours after SCG trigger has shown the equal results compared to 32 to 40 with IUI between 32 to 40 hours in some of the studies. For the timing of IUI in clomiphene cycle, the LH test is more effective than SCG trigger. So whenever you are using CC cycle, you should rely at more on LH test to decide the timing of IUI. After doing IUI, we always confirm a rupture for whether the follicle has ruptured, ovulation has occurred or not. If it has not occurred, then we always call the patient next day to find out whether ovulation has occurred or not. And if the ovulation has not occurred, then we change the strategy, stimulation strategy, trigger strategy, using antagonist, etc. in next cycle. But if you want to do a double IUI, especially in male infertility, the ideal time will be 12 hours and 40 hours after the SCG trigger if you are using SCG. But if you are using urinary LH kit, then on the day of urinary LH positive and next day will be an ideal time for double IUI. There is no advantage observed of down regulation, long down regulation in IUI cycle. In the single patent tube who start ovarian stimulation cycle, the chances of proceeding to IUI is approximately 60 to 70% because the cycle cancellation happen because of most of the time due to absence of follicle on the side of patent tube. The pregnancy rate was similar among both the groups based on treatment analysis, and pregnancy rate per patient was also a similar. In patient of unexplained infertility, whether you use a clomiphene, whether you use letrozole, the endometrial thickness hardly matters in the success rate. The thin endometrium is more common among the women with unexplained infertility undergoing letrozole IUI therapy than women with other primary diagnosis. However, the endometrial thickness is not a significant predictor of pregnancy outcome. In the woman with unexplained infertility and thin endometrial measurements may show improved outcomes compared to other women with similar follicle profile. So, in case of unexplained infertility, you should not worry much when you encounter a thin endometrium, especially when you are using oral drugs for the stimulation. In IUI stimulation, which gives better result, letrozole or CC? The conclusion of the study demonstrated that higher pregnancy rate trends in letrozole IUI cycle, which was 18%, then CC IUI cycle, which was 13%. There was no significant difference observed in letrozole pregnancy rate with IUI or time intercourse. And there was no difference between success rate in cycle of letrozole with time intercourse and CC IUI. So, conclusion was the routine insemination in the cycle of ovulation induction or superovulation with letrozole may not confer improved pregnancy rate. The ovulatory cycle of letrozole has got better success rate than CC cycle, and which is at par with the CC IUI cycle. A elderly lady with unexplained infertility, the CC with IUI results are same to FSH with IUI. So CC with IUI failure proceeding to IVF will take more cycle to conceive than proceeding directly to IVF. Meaning, in such elderly woman, if you have used clomiphene for IUI and if fails, and then you proceed for IVF, is going to take more cycle to conceive as compared to proceeding directly to IVF. This was a conclusion of one study. Whether AMH helps in predicting response and pregnancy in CCIUI for unexplained infertility? No. AMH level do not predict pregnancy outcome in couples with unexplained infertility undergoing CCIUI cycle, nor they are predictive of follicular response. Therefore, the patients with unexplained infertility and AMH level less than 1 nanogram should still be treated with CCIUI prior to IVF. So to conclude, the IUI success rate is best, and it is best indicated in a group of patients having age less than 38 years, ovulation disorders, normal ovarian reserve, secondary infertility cases are better prognostic value, more than 1 million progressive motile sperm inseminated, the basal FSH level less than 9, AMH level more than 5, and E2 less than 40 picogram. These are the ideal case for better and the best success of IUI. Thank you.